Hello, this is Dr. Maureen Markman from City of Hope, and I'm going to continue our conversation from last time where we were talking about precision cancer medicine. Last segment, I focused on the past. Today, I'm going to spend a few moments talking about the present. The present, of course, is a massive expansion of a role of precision cancer medicine with our understanding of somatic mutations, germline mutations, and critically, the molecular platforms that allow us to now not, spending when we first looked at the genes, the statement was it was several $billions to look at a single gene. Now we're at a point, and of course, that took years to do. Doctors Venter and Collins representing the private sector and the public sector, with President Clinton, of course, all known about that, but the world has changed. The term revolutionary is appropriate. But we now are able to look at the patterns in individual cancers, patients' genes, germline and somatic, for costs of, in the sort of the thousands of dollars range, and at timelines that are measured in weeks or less, to look at specific abnormalities in individual patients. So we actually have, standard of care in multiple tumor types with very specific abnormalities that are identified that lead to standard of care. Lung cancer is a wonderful example where one would hopefully not think about giving therapy in metastatic non-small cell lung cancer without finding out if there was an EGFR mutation or an ALK mutation, for example. That is standard of care. And of course, in breast cancer, we have now been looking for, obviously, HER2 overexpression. In ovarian cancer, the question of using PARP inhibitor maintenance therapy based on germline or somatic mutations is now standard of care. So standard of care with the use of these precision cancer approaches is evolving. Drugs are evolving, settings are evolving. It's a very exciting time. We are still largely focused, however, on, with some important exceptions, on the tissue in the solid tumor space and in specific abnormalities that might be determined with liquid tumor biopsies. This is an evolving area, which we'll talk about a little next time. But standard of care today clearly includes, without any question, in multiple tumor types, obtaining molecular profile of a tumor and using that to define the standard treatment, both in the front line and perhaps in the second line setting, in an increasing number of tumor types. This is a very exciting era. It's very important to emphasize how rapidly it's moving. And I end this section to talk about the increasing number of FDA approvals for drugs specifically based on the molecular presence of a molecular abnormality that are not related to the site of origin or the tissue of origin. Term that has been used is tumor agnostic. So finding these abnormalities from the FDA's perspective, and I think from everyone else's perspective, this should lead to the use of a particular drug independent of the site of origin. Questions remain as, well, when do you use it? Should it be first line, second line, third line? Much needs to be answered. The important point is, it's been recognized that the presence of these molecular abnormalities in certain settings should be an indication for using the drugs because they're effective in that setting in the presence of a particular molecular abnormality. There's no question that we're going to see more and more of these particular indications as we move along in our increasing understanding of the molecular biology of cancer. And I thank you for your attention.